Cardiovascular disease remains the leading cause of mortality worldwide. By 2030, annual deaths are projected to exceed 20 million. The greatest threat lies in the hidden nature of the disease. Fatal events often occur in vessels that appear functionally healthy to standard diagnostic tests. The standard reactive model of cardiology relies on exercise stress testing and invasive angiography to detect hemodynamically significant blockages. Hemodynamics refers to the dynamics of blood flow within the circulatory system. In this standard model, the clinical threshold for intervention is defined as a luminal narrowing of 70% or greater. Autopsy and angiographic data reveal a biological paradox. Between 70 and 75% of myocardial infarctions occur in vessels with less than 50% stenosis prior to the indexed event. Myocardial infarction is the medical term for a heart attack. Most acute coronary syndromes are triggered by the rupture of low-density lipid-rich plaques. These inflammatory lesions do not restrict blood flow before they burst. The standard diagnostic toolkit is misaligned with the actual biology of the disease. It monitors for a 70% plumbing issue, while the true threat is often a hidden 40% inflammatory lesion. Coronary artery calcium scoring, or CACS, is the current standard for detecting subclinical pre-symptomatic disease. CACS is a non-invasive CT scan that measures the amount of calcified plaque in the coronary arteries. CACS is useful for identifying calcified plaque, which acts as a reliable marker for chronic, long-term disease burden. This diagram illustrates the critical limitation of calcium scoring. The scanning beam registers dense calcified deposits, but the volatile pool of liquid lipid within the arterial wall remains completely dark and unrendered. To prevent sudden cardiac death, clinicians require a modality capable of quantifying the invisible inflammatory lipid pools that calcium scoring misses. A calcium score of 0 does not exclude the presence of rupture-prone lesions. Patients can be at high risk even when no calcium is detected. Atherosclerosis is a chronic inflammatory disease occurring within the vessel wall itself. Plaque can grow massively without narrowing the lumen. This is positive remodeling. The artery expands outward to accommodate plaque, hiding disease from standard angiograms. Atherosclerosis imaging, quantitative computed tomography, or AI-QCT, represents the transition from visual estimation to computational voxel-level quantification. AI-QCT is a software system that uses artificial intelligence to identify and measure different types of plaque in heart scans. The process begins with acquiring high-resolution coronary computed tomography angiography data. This is a 3D imaging test that uses a contrast agent to visualize the blood vessels of the heart. Deep learning architectures, specifically 3D U-net segmentation models, analyze the coronary tree. A 3D U-net is a type of neural network designed to identify and separate specific structures within three-dimensional medical images. The algorithm breaks the artery down into microscopic 3D pixels known as voxels. The system classifies these voxels by measuring their exact Hounsfield unit attenuation values, distinguishing tissue types based on X-ray absorption. This process enables the precise volumetric measurement, in cubic millimeters, of total plaque burden. The system isolates and measures the specific low-density non-calcified plaques associated with acute coronary syndromes. The software also generates an AI-derived ischemia index. Ischemia is a condition where blood flow and oxygen are restricted to the heart muscle. This index estimates actual blood flow limitation, providing a non-invasive equivalent to fractional flow reserve. Fractional flow reserve is a technique used to measure pressure differences across a narrowed artery to determine if a blockage significantly limits flow. AI-QCT enables the CT scanner to function as an automated biochemical laboratory capable of digital dissection. These capabilities have been evaluated in peer-reviewed prospective trials published in leading cardiovascular journals. The Credence trial demonstrated high concordance between AI-assisted analysis and invasive quantitative coronary angiography, supporting its diagnostic accuracy. The CONFIRM-2 registry tracked over 6,500 patients with non-obstructive disease across multiple countries. This graph shows that AI-quantified plaque features increased the area under the curve for predicting major adverse cardiovascular events from 0.62 to 0.75. Major Adverse Cardiovascular Events, or MACE, is a composite measure tracking severe outcomes like heart attacks and strokes. deep learning models are bottlenecked by the quality of the input imaging data. Better software requires better hardware. The next leap in hardware is photon counting computed tomography, or PCCT. Photon counting CT is an imaging technology that directly converts individual X-ray photons into electrical signals to create high-resolution images. By counting individual photons, PCCT eliminates much of the electronic noise found in conventional scanners. This side-by-side comparison illustrates a major technical upgrade. Standard scans suffer from calcium blooming, where bright deposits blur into surrounding tissue, but PCCT data keeps the calcium sharp and confined to its physical footprint. The CERTAIN study confirms that this synergy of hardware and AI reduces unnecessary testing and guides more appropriate medical therapy. Preventive cardiology is moving away from episodic interventions toward the longitudinal monitoring of atherosclerotic disease. Quantification of total plaque burden makes a treat-to-target approach possible, where success is measured by the objective reduction of disease volume. AI-based comparison tools allow clinicians to evaluate microscopic changes in plaque composition across serial imaging sessions. This split-screen model allows clinicians to verify the stabilization of lipid-rich plaque. As the disease regresses, volatile red lipid voxels are replaced by stable yellow fibrous voxels. In the Pacific 1 trial, AI exceeded expert human readers in standardizing this evaluation and reducing variability between different observers. Clinicians no longer have to guess if a statin or a lifestyle change is working. They can computationally prove that dangerous plaques are dissolving. As automated algorithms absorb the labor of voxel counting to image segmentation, the role of the physician is elevated. Clinicians are focusing on higher-level clinical decision-making, emphasizing individualized risk communication and therapy optimization. The next frontier involves integrating agentic AI systems and longitudinal digital heart models. Agentic AI refers to artificial intelligence designed to pursue complex goals and make decisions with minimal human intervention. These digital models will fuse AI-QCT imaging with multimodal data, including a patient's genomic and metabolic information. The biological reality remains. Most acute heart attacks are caused by visually small but biologically volatile lipid plaques. By leveraging AI-QCT to track high-risk plaque phenotypes before they rupture, cardiology finally addresses the disease before the patient ever feels a symptom.